Today we will look back at the year of clinical microbiology as seen through the lens of the Journal of Clinical Microbiology. 4 JCM editors have each selected a paper they consider to be among the best we published in 2024. Of course, there's no objective criteria for what we mean by best, so by best, we just mean papers that we like. Welcome to Editors in Conversation. Please subscribe to this podcast and rate or review it. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org. I'm your co-host, JCM Editor-in-Chief Alex McAdam. Editors in Conversation is supported by the American Society for Microbiology, which publishes JCM. And if you are a member of ASM, you can get up to 50% off publication fees when you publish in JCM or any of the ASM journals. I am joined by the co-host, Dr. Ellie Thiel. Ellie is an editor at JCM and a clinical microbiologist at the Mayo Clinic. Ellie, Happy New Year.
Happy New Year. I'm joining you guys from my childhood room, as you might be able to tell by the wallpaper.
We are also joined by a good friend of the podcast, Dr. Trish Simner from Johns Hopkins Hospital, where she is director of the Medical Bacteriology and Infectious Disease Sequencing Laboratories. Trish is also an editor of JCM. Trish, I'm glad you can join us.
Hi, friends. Happy to be back.
And we are happy to welcome another good friend of the podcast, Dr. Romney Humphreys. Romney is the director of the Division of Laboratory Medicine and the medical director of the Microbiology Laboratory at Vanderbilt University Medical Center. Romney is currently the mini review and commentary editor for JCM. Romney, welcome back.
Thanks for having me. Great to see you all.
And I have a little announcement to share with our friends and listeners. So everybody leading close, because this is just among the thousands of listeners to the podcast. Romney Humphreys, Dr. Romney Humphreys, will be the next editor-in-chief of JCM.
Woo! Yeah. Congrats, Romney.
Thank you.
Really
I'm very excited. Yes, it's a huge honor and huge shoes to fill, Alex, I have to say.
Well, I am very excited. I am absolutely delighted that you will be starting in July, and I'm looking forward to the changes that you and the editors will make to JCM. I'm sure you will do wonderful work. All right, so let's go ahead and jump right into it. I think, Romney, you are going to give us your best paper first.
I am, yes. So I picked something maybe a little bit self-serving, I don't know, but it's a paper by Dr. Kyle Rodino and members of the Personnel Standards and Workforce Subcommittee of ASM, which is defining the value of medical microbiology consultations. So I loved this paper because I think for those of us who sit in these roles, we sort of understand how many consults we do in a given day, and we understand the value that we bring to the lab. But it really hasn't been quantified before. And I think sometimes, I don't know, speaking for myself, I feel a little sense of imposter syndrome being a PhD in a world of MDs. But I have to say this paper did a really nice job kind of laying out all the important things that we do day to day. So I did.
Romney, I just want to say having an MD does not make one invulnerable to imposter syndrome.
Well, I suppose that may be true. You shouldn't give away your secrets. But I did love this, and I'm here in the lab today, and I walked through, and so it's Friday afternoon. And so what kind of consult do you guys think I might have gotten walking through the bacteriology lab, specifically the blood bench, specifically looking at a gram stain where everybody was very anxious? So those tiny gram-negative rods that just aren't growing yet. So, of course, this is like always the Friday afternoon consult. Thankfully, I think it's going to be a Haemophilus based on the patient's characteristics, but I was happy to see the lab was, on the spot and paying attention. So anyways, back to this article. They did a fabulous job taking a look at several different hospitals and their clinical microbiology labs and the kind of call service that they do. So the hospitals involved were Children's Hospital Los Angeles, the Hospital of the University of Pennsylvania, Barnes-Jewish, Nationwide Children's, Mount Sinai, the University of Maryland, and Deaconess. And so the nice thing about this selection of hospitals is that it included a range of medical microbiologists on staff between 1 and 4, a pretty broad range of specimen numbers, and a broad number of trainees that they had involved in their call service. And so what the group did is that they took note of all the calls that they received for a 1 to 2 week period in the fall of 2022. And essentially they assessed them to see what were the types of calls we get, who was making the calls, who is being phoned. Is it the lab director? Is it the technologist on the bench? Is it the trainee? And the type of consult. And what I really loved as well is that they then classified these consults based on whether or not they had a direct impact to patient care. So, for example, helping to determine the best testing to order for a really complicated diagnosis like cysticercosis, helping in evaluating multi-drug resistant organisms and evaluating the resistance mechanisms. But then they also looked to see if the consult maybe had an indirect impact, so it would have a benefit to future patients, if it maybe had a role in diagnostic stewardship, education, which is a huge value I think we bring, cost savings, as well as providing guidance on the testing process, be it specimens to collect, tests to order, all the way through to what the heck do these results actually mean. And so their findings were interesting. They had between 17 and 164 consults in a 2-week period. It was about a 50-50 split between internal and external consults, so to the lab or outside the lab. So either it's a bench technologist who's making the consult or a physician outside the lab. The internal consults were mostly during rounds, which I don't think is too surprising. And I think actually doing bench rounds is one of the primary values that the lab director brings. I think we all, come across unexpected circumstances or situations. You're like, okay, wait a minute. How long have we been doing that particular thing for? And is that really the right thing for us to be doing? But also providing guidance to the technologists on how to work up cultures, how to think about reporting susceptibilities or even doing a susceptibility test, what to reject, all that good stuff. So I think none of that is a surprise, but I do think it really adds to the value of what we do. And the external ones were mostly from the infectious diseases physicians, which they made a really interesting point. We interact with our infectious diseases physicians all the time, but they also perhaps interact with us most because they know that we're a resource. One of my roles here at Vanderbilt is on our lab formulary committee as an observer. I'm not a voting member, but we present a lot of diagnostic stewardship initiatives to the lab formulary. And one of the big things I did during the pandemic, which I know a lot of other people did, was get rid of all of the superfluous, non-necessary testing that we did so we could focus in on, COVID. And so many times the urologist or the surgeon on the committee would say, wow, this is a fabulous resource. We had no idea that there was this person in the lab that we could phone to get all of this help with these. So I think, that really kind of speaks to a place that maybe we can get out of the lab a little more, talk more with different clinicians. So taking a look at how much effort and time, about more than 75% of the consults took less than 15 minutes. I think generally we pretty clear, what to do with these. For my one I had earlier today, it's tape up those plates. Let's take a look at the growth. Let's take a look at what's going on with the patient. And, we know what to do with this small gram-negative rod. And they really did mention, and this is something I'd love to hear all of yours experience on, but anecdotally, all the directors felt that the number of consults that they were getting from bench techs were far more frequent than they had been in years past. And they kind of said this is maybe a little bit due to the shift in the workforce and how we have fewer bench technologists with years and years and years of experience, but also we have all this technology that makes it hard for people to learn basic microbiology. So I don't know if you guys have observed that. It definitely spoke to me when I was reading that section of the paper.
How about you, Trish?
Yeah, definitely encounter the same, Romney. The other thing that I'll add is that, we're getting more specific identifications by MALDI, where, in the past we used to call them criniform gram-positive rods. Now we're getting names to all these things. So I think in addition to advanced technologies and maybe kind of losing a little bit of the knowledge of the biochemicals and things, we're also getting a lot more specific information that allows us that are then questioning, do we want to work this up further? Do we need susceptibilities on this? What does this mean in the context of the patient? So a lot more kind of diving into the chart and trying to understand the importance of some of those identifications.
I don't think I'm getting more consults from the bench, but we've always gotten a fair number of them. And then a tremendous number of emails and consults from infectious diseases as well.
Yeah.
What about you, Ellie?
So my lab's a little bit of an outlier. The median years in my lab is about 20. So it's a really smooth sailing ship. Wasn't really impacted, interestingly, by COVID. But the other lab, I co-oversee the virology lab, definitely many, many more calls than my IDS lab. And it is because of just the new influx of young techs on the bench. So yeah, would agree with that.
Yeah, that's interesting. I have to say, when I was at UCLA before I moved to Vanderbilt, the median age of experience in our lab for our techs was something like 30 years. It was ridiculous.
Incredible.
And amazing.
It's fantastic.
It was like a fabulous place, to learn and to work. And then one year they all retired. And I was so nervous. And you know what? All those junior techs totally stepped up, and they were fabulous. It was so cool to see. So I guess my point being, just because you're young doesn't mean you can't be fabulous at your job. But I do think that as people have been trained with MALDI, have been trained with automated susceptibilities, have been trained with all these things, I do think one of the values the director brings is really making sure that the techs understand the basis behind what they're doing. So anyhow. So anyways, all told, I thought it was a great start on this story. I think that they did a good job sort of describing the consults. If I had a wish for the paper, I think it's really hard to quantify the value, right? And so they talked about cost savings, but they didn't really put a dollar number to it, which I understand why they didn't. But I do think understanding that could be of help. And it's also hard to quantify, when we think about RVUs for other physicians, these units of work, we don't have a way to quantify those. And that's true in clinical microbiology. It's true in clinical chemistry. It's true, across the field of lab medicine. So I just, there's a lot of smart people out there listening to this. So I guess maybe that's the next step. So anyhow, that was my favorite for the year.
That is a great choice. I have noticed that there's a lot of variety in how people cover the consult service. So we have here at Children's Hospital in Boston 2 clinical microbiologists, myself and Dr. Pollack. We each have areas of the laboratory that we primarily oversee, but we both cover the call for the entire laboratory. And we have a shared email address, and that's how people contact us. And it works well for us. What do you guys do, Trish, at Johns Hopkins?
Yeah, us is a little bit different. So we're very subspecialized. So I oversee bacteriology along with Dr. Karen Carroll. And then we have individual directors for virology, mycobacteriology, mycology. And so a lot of the times, the more specific consults relative to those sections go to those specific directors, whether you're on call or not, which is kind of a challenging situation where you're trying to take some time off, but at the same time allows consistency and that specialization in those consults to come through with that. But the good thing is that we're trying to build more of that model now, Alex, with we have now 2 CPEP fellows, and try to have them provide more consistency and utilize the faculty on call more than the specialized directors for the specific consults. But a little bit of a different model to what you're used to there, with really relying on the specialization of the directors.
I think consistency, I'm going to jump in, I'm sorry, and then we'll go around the table. But I think consistency is really important. And my colleague and I, we check in with each other very frequently if it's a new question or if we've introduced a new test and we're getting questions about it, because we want to make sure that we're giving the same answers.
Mhm. Yeah,
Carrie, Ellie.
I think we're even a little bit more subspecialized than Hopkins. So we have 7 lab directors overseeing each of our areas, but then some of us also kind of like if it's an STI question, that will now come to me. If it's a transplant virus, it will go to one of the other lab directors. So that kind of makes it challenging on the clinical side to kind of keep track, who is specializing in what these days. So most of our calls go first directly to the on-call fellows. So we have 3 CPEP fellows at any one time. And then they kind of triage, if you will, and then it goes to the lab directors if there's any issue that they can't necessarily handle or if they have questions. So it's the Hopkins way, but a little bit more expanded. Consistency is hard, I think, especially as new CPEP fellows come in. So getting them trained and onboarded. But we make it work.
Ramnik?
Yeah, we do a bit more like you, Alex. So we have 4 clinical microbiologists, myself included. They still let me in the lab every now and then, even though I'm not technically medical director of any one lab. And they do let me do call once a month, which makes me feel like, I don't know, I'm still a microbiologist. But we do the same thing. So we split weeks on call. Everybody does a week. We rotate. We actually early on recognized how challenging it was to have the consistency. And so we meet for an hour every Monday with the fellows and talk about the week that was and the week that's coming, and just, kind of align on different things that are happening. We also have an Army fellow with us this year who, his name is Turner Conrad. He is amazingly organized. And so he walked into how we were tracking calls and dividing things. And I think he had a tiny aneurysm because we were, just texting each other or emailing. So he set up this Teams channel where the fellows log all of their calls and then the attending signs off on it at the end of the week so that we can prove that we're supervising them and also kind of have some consistency. And the cool thing about that is I actually looked this morning, and since last July, we've done 1,138 calls, which is a big number when you look at a full year and a half. So that was kind of neat.
Trish, I think you're up next. What paper did you choose?
Wonderful. So I'm going to shift gears a little bit. It's a little bit pertinent to consultation and how medical microbiologists play a role in antimicrobial resistance mechanisms, as Ramani touched on, and how sometimes we get consulted on what is the putative mechanism, etc. So this was actually part of this paper was presented at ESMID Global in Spain this past year, so I was excited to see it submitted to JCM for publication. So it's GPT-4-based AI agents, the new expert systems for detection of antimicrobial resistance mechanisms. There's a question mark at the end. I don't know if you heard it there, but there is. It was published in November, and the 2 primary authors were Dr. Christian Giske and Michelle Brenson, and the work was done in Dr. Oliver Nolte and Adrian Egley's labs at the University of Zurich in Switzerland. And so, as you're all aware, large language models are kind of taking over what we do, whether we're doing a Google search, it's summarizing that search data for us, etc. So I was interested to see how these kind of artificial intelligence, these large language models can help us in laboratory medicine. And so this study explores the integration of large language models like generative pre-trained transfer, GPT, agent models into the field of laboratory medicine, specifically in diagnostics of antimicrobial resistance. So with the growing challenge of AMR, there's a pressing need for innovative solutions that can enhance diagnostic accuracy, efficiency, and speed within the laboratory to hopefully help the clinician on the other end with more rapid tailoring of therapy as appropriate for when resistance is encountered. So before I dive into the paper, I thought I would summarize what is a large language model. So a large language model is a type of computer program designed to understand and generate human language and logic. And these large language models work by understanding and generating human language by looking at a very large amount of text written by humans and figuring out the patterns and rules that govern the way that language works. And so in this study, they explored the capability of artificial intelligence, or in this case, specifically large language models, to support the existing two-step confirmatory process recommended by the European Committee on Antimicrobial Susceptibility Testing, so EUCAST, the European equivalent of CLSI. And their two-step algorithm is for detecting beta-lactamases, in particular extended spectrum beta-lactamases, plasmid-mediated AMP-C beta-lactamases, and carbapenemases among gram-negative bacteria. So what they did is they compared a non-customized GPT model, a customized GPT model, and I'll go into how they did that, with human-based assessment of susceptibility testing results to screen for beta-lactamase production among gram-negative bacteria. So this was a retrospective study that included 225 gram-negative bacilli. The reference method in this study was the standard of care results that were produced by the University of Zurich. At their institution, they used distribution for susceptibility testing, and specifically, they used the SIR web scan system to measure zones of inhibition, and then they utilized EUCAST guidelines to then screen and then confirm for resistance mechanisms if the screen is positive. So based off of the zones of inhibition, they applied the screening criteria by EUCAST that is automated in their SIR-Web expert system. And so for AMP-C beta-lactamases, they look at cefoxitin and ceftazidime resistance. For ESBLs, they look for cefpodoxime resistance. And then for carbapenemase, they look at ertapenem and meropenem based off of EUCAST guidelines. If they meet screen positive for one of those three criteria or one of those three mechanisms, then they proceed with confirmatory testing. And at their institution, they utilize combination DIS tests to confirm the presence of ESBL, plasmid-mediated AMP-C, and carbapenemases, in addition to lateral flow assays that detect CTXM or the big five carbapenemases. So based off of their standard of care results, they assigned those 225 gram negatives into four phenotypic categories. One, which was ESBL, so there was 111 that fell into that category. The second was plasmid-mediated AMP-C, which there was 32 that fell into that category. And third, carbapenemase, which was 23 that fell into that category. And the remainder were classified as none. They were not an ESBL, an AMP-C, or a carbapenemase producer. So for each isolate, they have four categories that are assigned to each isolate, whether they fell into none, ESBL, AMP-C, or carbapenemase, for about 862 category phenotypes that were subsequently analyzed and compared to these chat GPT or these GPT-based models, as well as medical microbiologists analyzing the data as well. So one large language model they didn't touch, but a second one they tried to customize a little bit. And they named this customized GPT agent EUCAST GPT Expert, and they utilized the commercial version of ChatGPT, which is available through OpenAI, to create a pre-classification system to screen for potential resistance mechanisms. So ChatGPT is a non-trainable a large language model that can be customized to perform a specific task by providing documents containing further information. And the way they customized this GPT agent was by providing the EUCAST breakpoint tables, the EUCAST guidelines for detection of antimicrobial resistance mechanisms, and EUCAST expert rules to customize that large language model to screen for any of those four phenotypic classifications that I discussed earlier. Once they created that model, they then started to provide input into the non-customized and the customized one that they provided the EUCAST documents to customize it. What they did is they provided images of the distribution plates from SIR-Scan and a table detailing measured inhibition zones for each antibiotic for every one of those 225 gram negatives into those models and asked for a standard output. and prompting. So that standardized prompting included interpretation of the image and table. And then they asked the model to provide an output table for the 4 phenotypic categories, and they required the model to provide a binary response as yes or no, along with a likelihood analysis as very likely, likely, unlikely, or very unlikely. And then also asked if there was something classified as a resistant mechanism with a high likelihood, then the recommended confirmation tests would also need to be recommended by the model according to the UCAS guidelines. For each of those, they also asked the models to give a short description of why they were responding in a particular way based off of those zone diameters and images provided to the system. From there, they compared the output performance, so sensitivity and specificity, relative to the reference method. And they did this for the non-customized model, the customized model, and they had 3 boarded medical microbiologists also look at those images and interpretations and provide their own response to those 4 phenotypic categorizations. For the medical microbiologists, there was 3 of them that did this independently, and there was some variability in the responses. And so they took the median of those responses for the comparisons. In addition, I thought what there was really interesting is they actually also prompted the customized UCAS GPT expert 3 times with the same data as well, and utilized the median output for analysis as well. So kind of looking at the reproducibility of these GPT agents, which is fascinating as we get into the results. So the non-customized GPT performed poorly, so I'm not even going to discuss it anymore. So that was the model that they didn't try to train or provide any information up front, and it didn't perform very well. But the customized UCAS model, relative to the standard of care results, performed pretty well. It a greater than 95% sensitivity for ESBL and AMP-C detection, and 100% for carbapenemase detection. However, the specificity wasn't so great at 69% for ESBL, 86% for AMP-C, and 100% for carbapenemase. Did really well with carbapenimases, I should say, overall, from a sensitivity and specificity standpoint. However, from a specificity standpoint, it had a propensity to overflag ESBL and AMP-C producers. The human results relative to standard of care generally exhibited comparable sensitivity to the customized GPT model, but exhibited higher specificity, in particular for ESBL and AMP-C phenotypes. When looking at the reasoning for the responses of whether they thought there was, the screen positive for particular mechanisms, the humans provided a median 8 words explaining themselves, whereas the UCAS GPT agent was quite verbose in its response. It often gave a median of 158 words. And the authors were kind and said it could be helpful for educational purposes or for complex cases where thorough explanations are warranted. However, as we all know, verbosity is not practical and brevity is often preferred in the clinical setting. So I thought that was interesting that it wanted to explain itself really well of why it was choosing a particular response.
Maybe a little too defensive, right?
It wants to cover all bases. And then when looking at the concordance between the 3 human experts, there was about a 94.4% concordance, which was pretty good. But when looking at the UCAS GPT expert, and they prompted it 3 times with the same data set, the concordance was only 81%, which I found was fascinating because it fed in the same information. It had all the same UCAS guidelines, but there was some contrasting information depending on when they ran it. So its reproducibility doesn't sound all that great, which I thought was interesting. I tried to look, do they try to provide further cues when they reprompted it or anything, but it sounds like they just put in the same data, and the concordance was about 81% when doing that, which was fascinating. So I found this study highlighted the potential and limitations of customized AI agents, in particular to screen for suspected beta-lactamase resistance mechanisms with disk diffusion data. it was a retrospective assessment. So it kind of looked at, what is the potential safety and baseline performance of this? Obviously, we need to understand how these models work a little bit more and start to refine them a little bit better. That lack of specificity, although the author has said because it's got pretty good sensitivity for detecting the resistance mechanism and really highlights the ability to recognize resistance mechanisms. They said this, although the specificity was lower, the authors highlighted that since this was a pre-classification screen and additional confirmatory testing would be required, the results were acceptable. That being said, we all know that our staff are, worked even more lately. We're on, less work. Have workforce challenges. So that additional confirmatory testing that would be required for that lack of specificity on the screening definitely would be worrisome as a microbiology director. And of course, it adds further costs to testing in the laboratory. But this data from the study may serve as a blueprint to track the large language model progress and as a benchmark for in silico data sets. Repetitive testing of the same data can allow us to track the performance evolution over time and try to understand. Also, these initial studies are important for us to understand what type of regulatory processes are required and validation are required for these types of new artificial intelligence tools that we're evaluating for the clinical lab. Any questions or thoughts?
Humans for the win.
Yes, we're still winning.
We're still going to have jobs, at least for a while.
Right.
What do you make of this? This is more in your area than
yeah, it is. So I wondered if it was getting smarter over time. Like, did it improve its performance, and was that why the specificity wasn't great?
So that's what I was trying to understand, because they called the ChatGPT a non-trainable model. So to my understanding, and I used a large language model to get to this understanding, by the way, that these non-trainable models are built from scratch and require significant data and computational resources and can be learned through the data set. Whereas the customizable models like ChatGPT are models that exist and are fine-tuned and adapted to specific tasks or domains, and that it's not necessarily learning how to be better or how you need to train models to get better and understand how you classify things. I think it was more that maybe it was just I don't know why the reproducibility wasn't so good, but it would make sense if they were queuing it with further information, like if it's sulfoxetine susceptible, it's unlikely to be an AMP-C producer, and then it goes again. And maybe that could be due to the reproducibility, but I didn't find that in the data. But my understanding is customizable models are models that can be already built and tailored to a specific situation, but do not perform as well as they're not as fully trained as some of the trainable models.
Interesting. I mean, I guess for me too, how long have we been trying to deduce resistance mechanism from, a couple discs or, a couple MICs? And I'll tell you, when we first started doing whole genome sequencing on bacteria, I was wrong like all the time. I'm like, oh, for sure, this is blah, blah, blah. And then I'd sequence it and it would be the exact opposite of that. So I kind of wonder, if we're just asking too much of our phenotypic tests, and having some kind of fancy computation on the back end probably still doesn't make kind of a tarnished test all that better. I don't know. Lots of hand waving, it feels like. Even the GPT program was hand waving with its lengthy answers.
Right. Yeah, fascinating to see it being incorporated into laboratory medicine and what we're going to be faced with next, right? So
it was a great choice. I thought about picking that one also, so I'm glad you did. I've given myself the privilege of going last, so Ellie, you're up next.
Well, I did not think about picking that one, Trish.
I wonder why.
This year I really was intrigued by studies that looked at alternative easier to collect sample sources for testing. And I think, looking through all of the studies, there were some pretty unique and creative approaches this year that were published. Things like testing urine for syphilis. There was another study that collected tears and tested it for beta-D-glucan as an alternative means to diagnose fungal keratitis. So all of them are pretty cool, but the one that I thought I'd talk about today is a study by Rachel Wood and colleagues from the University of Washington in Seattle. And they looked at the diagnostic accuracy of tongue swabs for detection of TB. And they looked at 2 different molecular assays for this. And really, the use of tongue dorsum swabs in particular is not necessarily new, but this study was the largest to date, looking at the source as an alternative to sputum for TB. And that in itself, so using a tongue swab obviously can increase testing accessibility, which remains a key WHO goal. This study also used dry swabs and validated a 15-minute processing step, which is very different compared to previous studies that used swabs in various different medias, and they had like a 45-minute or longer processing step before testing. So those are some improvements that the study looked at. And then they evaluated the Cepheid Expert Ultra assay, and then a newer assay, the MolBio TrueNat, I think I'm pronouncing that right, MTB Ultima PCR assay for use of these tongue swabs. And the reference standard method that they used was sputum culture or results from the Expert Ultra assay done on sputum. So the study was done at the University of Cape Town in South Africa, where they enrolled patients into 2 cohorts. Cohort 1 was used to look at the impacts of oral hygiene or food and drink intake on swab results, and they did that on 100 patients with confirmed TB. And then for cohort 2, those patients either had suspected TB or sputum confirmed TB. For these collections, they used the Copan Flax swabs and collected at least 2 swabs from each patient. Interestingly, cohort 1, they all did self-swabbing at home, whereas for cohort 2, which were again the suspected cases or confirmed cases, those were all clinician-collected swabs at the time of patient presentation. So getting into their findings, even though the patients for cohort 1, that whole part of the study was dedicated to look at the impact of food and kind of oral hygiene intake on PCR performance, the study didn't actually include that data. Instead, they just indicated that only swabs collected at least 30 minutes before any food or drink intake occurred were included for the study. So with that, when they looked at the Expert Ultra and MolBio assay performance on these swabs, they had 241 sputum TB positive patients. The Expert assay had a sensitivity and specificity of 75 and 100% respectively, whereas the newer MolBio assay had a sensitivity of 72 and a specificity of 96%. Compared to the Expert assay performed on sputum. So overall, similar performances for both methods. They were also able to show that the sensitivity of these assays was not surprisingly higher in patients with higher sputum semi-quant results that are provided by the Expert assay, with 92 to 100% of tongue swabs being positive by the MolBio, and the Expert assays in patients with medium or high semi-quant results. That sensitivity fell to 55% or lower for both assays in patients with low to trace TB levels, which overall just indicates that using tongue swabs really wouldn't be ideal for those more paucibacillary TB infections like in kids or in patients with milder cases. So overall, I like this study because it nicely kind of expanded on prior studies showing that tongue swabs with some additional optimization are really probably an acceptable and easier and safer way a alternative way to test for TB compared to sputum samples. And I think this is probably something that we'll see more and more in the future, especially in regions outside of the US where TB is much more problematic than here. So tongue swabs for the win.
It is awesome. Anything that increases access to testing is a win.
Yeah, agreed.
Ellie, I might have missed it. Did they do it first morning, or is it any time during the day, or?
So anytime during the day, but they can't have had any sort of intake within 30 minutes. That was their one requirement. It had to be 30 minutes or longer since your last eating event. I wish they had. Oh, hello, buddy. Sorry.
It doesn't work on dogs.
Apparently your puppy's excited too.
I wish they had shown more data on, sensitivity after ingestion or brushing teeth or what have you, but they didn't show it this time around. So it was interesting.
Ellie, you mentioned tongue swabs were new. Is that just something is it making a comeback? Is this something they looked at back in the day and they wanted to reevaluate it due to increased sensitivity of the molecular assays now?
Yeah. So I meant to say it's not new. So it has been looked at outside the US mostly, but it's been small studies. It's been using swabs and various buffers and media that had to be stored cold. So one of the key kind of overall improvements of this is use of the dry swabs, and then including over 150 patients with TB to look at the sensitivity. So it was really kind of building on those smaller studies from previous years.
Thank you, Ellie. All right, so that brings us to the last paper, which is the one that I chose. And the paper I chose is titled An Exception Reporting Approach for Wound Swab Culture, Effect on Post-Report Antibiotic Initiation. And this was by Max Bloomfield in Wellington, New Zealand. And we also had a commentary on this paper by Blake Buchan at Medical College of Wisconsin. And that was titled When Less is More, The Art of Communicating Clinical Microbiology Results. And Trish, you were the editor for both of these. I chose this paper for two reasons. I particularly liked it for these two reasons. The first is that it addresses a question that we talk about and think about a lot, especially in bacteriology. And that is, if we report it, will they treat? Because we often identify organisms we are not familiar with. Then we go and look them up to find out whether they're possible pathogens. We find a number of case reports, each of which says this is an emerging pathogen. And what do we do? Should we report it? So that's the first reason. And then the second reason is that this really follows the effect of the clinical microbiology laboratory all the way through the process. So does the provider change their behavior based on our report? And how does that affect outcomes in the patient as well? So it really illustrates the importance of what the clinical microbiology laboratory does in terms of our reporting. So in terms of the background for this paper, I think all of us worry about wound cultures that are collected on swabs because we don't know whether the organisms that grow from those cultures are actually causing an infection or whether they are superficial colonizing organisms that don't really require treatment. So they asked whether reporting only those organisms that are resistant to standard recommended antibiotics would change antibiotic use in community or outpatient wound swab cultures. And specifically, whether it would change the frequency with prescriptions for antibiotics were given after the laboratory report was issued. So the setting, as I said, was a laboratory serving the Greater Wellington region of New Zealand, which is the capital of New Zealand. It has a population of 500,000 people. And in that laboratory, they usually report the traditional pathogens from wound cultures, including Staphylococcus aureus, Staphylococcus lugdunensis, and beta hemolytic streptococci, as well as others. And you can look at the paper for the details on that. Interestingly, they report the results when all of the results are available. So they don't report the gram stain, then the growth, then the identification, then the susceptibility. They wait until they have everything and they issue a complete report. And that bears on how the results are interpreted. And the other thing is that the treatment guidelines for the community setting are widespread and widely used and widely known. and they are treatment with an oral beta-lactam, which is effective against methicillin-susceptible Staph aureus, but not methicillin-resistant Staph aureus, and that's flucloxacillin, which is not used in the US, but is used in much of the rest of the world, or cephalexin, a first-generation cephalosporin. And those are recommended for uncomplicated skin and soft tissue infections in non-allergic patients. The study is a before and after study, and so there's an intervention, and then they compare the time period before the intervention to the time period after the intervention. The total time period was from all of October in 2021 through the end of December in 2023. And the change they made was this. On March 1st in 2023, they began something called exception reporting. And exception reporting in this paper refers to not reporting some stuff. And specifically, they don't report methicillin-susceptible Staph aureus, methicillin-susceptible Staphylococcus lugdunensis, and beta strep. They did have a pretty long comment that they put into the report, and I'm not going to read the whole thing, but I'll just read the beginning of it, and it is, no significant organisms resisted to standard empiric therapy, flucloxacillin or cephalexin, identified. And then it went on to provide instructions about how to contact the laboratory. It provided a link that provided context for the report and for the study as well. And the providers had access to that report that explained what organisms might be there when this comment was being issued. So in a sense, they knew that this comment meant there's Staph aureus or there's Staph lugdunensis or there's a beta strep present in the culture. There were a large number of exclusions that took patients out of the study. If the organisms were resistant to those antibiotics, of course, they were not included in the study. If the patient was known to be intolerant to those antibiotics or had been started empirically on another agent, that took them out of the study. Patients younger than a year, patients with specific clinical findings, including recurrent boils or surgical wounds, and then eye, ear, and nasal swab samples, those were eliminated as well. The last group, presumably because they're not really wounds. And then they had to make a change during the study itself. So in September, based on feedback from the requesters, the ordering providers, samples from patients who had already been started on antibiotics at the time of sampling, as per the request form, were also excluded from exemption reporting. So that's a lot of exclusions, and it ended up excluding just under half of the patients who might have been included in the study. So they had a large database that had been assembled for previous work, and they had patient-matched data on wound swab culture results and antibiotic prescriptions. There were over 12,000 samples before they made the change, and there were over 6,000 after they made the change. Overall, about half of the samples had methicillin-susceptible Staph aureus, with the other exemption reporting organisms present in much smaller numbers of samples. And then they classified each culture or patient by the timing of the antibiotic prescription. So first was the test and wait strategy. And that meant that no antibiotics were given from 5 days prior to swab collection up to the time that the result was issued. So that's test and wait, and it was for about a third of the patients. The other group was test and treat. And that meant that antibiotics were started at the time of the culture or within 2 days of swab collection, or in patients, or if patients were on antibiotics when the swab was collected. And that was about 2/3 of the patients. There's a lot of good demographic data. There were some differences between the two groups that we're going to discuss. Take a look at the paper if you want to understand that stuff. It didn't actually bear on the final results. So for their primary outcome, they asked a question. It's a little complicated, but for patients whose culture qualified for exemption reporting and who were initially in the test and wait group, were antibiotics started within 5 days of the report in the pre-change group and in the post-change group. And the results were really dramatic. Before they implemented the exemption reporting, 49.5% of patients were started on antibiotics. After they changed their reporting style, it was dropped to 25.1%. And it was a precipitous drop. There's a nice figure in the paper showing how quickly it changed after they changed their reporting style. Now, I said that there were a lot of patients who were excluded from the study because of age and other clinical criteria. Among those patients, there was no change, as you would expect, because they all got the conventional report. They looked at a number of secondary outcomes, including whether antibiotics were dispensed within a longer time period, 30 days. And here they found the same result. So 59.7% of patients got antibiotics within 30 days in the pre-change group, 37.8% in the post-change group. Hospital admission within 30 days for an infection at the site that had been swabbed were the same between the two groups, 0.9% and 0.7% pre and post-change. And then repeat wound swabs within 30 days, which would indicate that the lesion was not healing, the wound was not healing, were also similar between the pre-change and post-change at 3.7% and 1.5%. So those were really the significant results from this. It was a really marked decrease in administration of antibiotics when they changed their reporting style. To me, it is really striking that the providers knew or could know that the exemption reporting comment indicated the presence of methicillin-susceptible Staph aureus, methicillin-susceptible Staphylococcus lugdunensis, or a beta strep, but the difference was in whether you named the species of the organism or not. There was no evidence that significant infections went untreated when they initiated or used the exemption reporting. And overall, the suggestion is that samples were collected from wounds that did not have evidence for infection. And reporting the organism identity is what led to the treatment. There were some good caveats to this study that the authors carefully considered and discussed. The first of these, which I think struck me as I was reading the paper, was that I could never do this. I could never do this because we don't have uniform recommendations that are followed for empiric therapy. There's much more diversity of clinical practice, and we don't collect complete clinical information at the time of ordering the way that they did in this study. So those really lent themselves to this change. They also noted that there was some frustration among providers that the lab was withholding information. And this was mostly found when the provider was following the test and treat strategy, because the demonstration of an organism being present would justify the treatment. So they later made an exception. If the patient was on treatment, they did not use exception reporting. They noted that this change was great for patients, but it did not really help the laboratory at all. It does not save time or money in the laboratory because you still do the complete workup. It's just a matter of what you report from the laboratory. And then if you go through the kind of numbers that I mentioned, antibiotic use was reduced by about half, right? But that could only happen in the test and wait group, which made up a third of the patients. And then it could only happen in the non-excluded patients, which were half of the patients. So that's a 1/12 of the patients who avoided antibiotic administration based on this change to reporting, which is still, to my mind, awesome. So this paper really underlines the importance of the microbiology laboratory report, and it reminds us to be very thoughtful about how and what we report, because naming an organism can lead to treatment that might be unnecessary.
Thanks, Alex. Did they look at the potential? They also, I think, did they go back and look to see if there was any negative impact to, not withholding that information? I can't recall if they did that in the study or not.
They did, in the sense that they looked at whether patients ended up being admitted to the hospital more frequently, and they did not, and whether a repeat wound swab was needed, and that was no more frequent as well.
So I just thought it was a really nice study that kind of looked at alternative ways to us reporting. Like you said, it's a challenge in the lab of what do we report to make sure there's positive impact on the patient. And whenever you start to overname things, then the physician on the other end tends to feel obligated to treat it, right? And that's even highlighted even further by this, that comment. Like you said, the information that they're essentially telling them there's an organism present that may be pertinent, but your empiric therapy covers it, right? So, that reduction in treatment is fascinating, and I thought was exciting, and makes me want to think, how can we rethink the way we do some of the reporting in the laboratory as a whole? But do think that I do think there might be some physicians that are not exactly happy if we're withholding some information. In quotations, withholding information, but they had it, like you said, they had it ready if they called to release, to have it ready to release, right? You weren't delaying anything by this. If they
and they provided an email address that you could use to contact the laboratory to get the additional results if you wanted them.
Yeah, but people hate phoning the lab for that kind of thing, sadly. I think this is so interesting. I find the whole psychology of how we report stuff fascinating, right? Like urine cultures, oh my goodness. I've been trying to convince people here that we should just write no significant organisms, which can be interpreted as, oh, it's negative, but that's not really what we're saying. We're just saying there's nothing of significance here. And I have a kind of a funny anecdote about this. When I first started, we did P&A fish. Remember that test for yeast? And we had this comment that we put on our report that we thought was so clever. That was, Candida albicans, greater than 99% are susceptible to fluconazole. And I was like, this is great. We're doing a good job saving all this echinocandin use. And actually what we found is our echinocandin use went up. And it's because the house staff were like, oh my gosh, Candida albicans can be resistant to fluconazole. And like that 1% on our comment is what they read. And I could have never predicted that it would backfire in that way, but it was a really good lesson to, I guess, trial out your comments with lots of different groups.
That's a great anecdote. My summary of this paper is, if you name it, they will treat.
Yeah. So, I'm curious about this. So we have a counterpoint in the journal coming out about cascade reporting. And the people who were against the cascade reporting, which I won't give too much away because I want people to read this, but they felt that this nudging of behavior was maybe detrimental to long-term learning. In other words, because it changes your behavior, but you don't really know why it's changing your behavior. So therefore, you can't learn to be better in the future. And so the minute you take that nudge away, so if you go to a different institution or whatever, you're just going to revert back to your old habits. And I thought that was interesting. I was curious what you guys thought of that. What do you think, Trish? Do you think that's true?
Yeah, I don't know if it's the loss of the knowledge behind it. I've definitely heard, I've presented this in different parts of the world, I will say in the US and outside. And I would say that depending on, different cultural or perspectives at different parts in the world, I would say the physicians feel with cascade reporting, especially, that we're withholding pertinent information to them. And so that is another kind of fear of this withholding of information. The loss of knowledge is interesting. I would actually think it's better for learning, right? Because we're kind of guiding them towards what is the more appropriate therapy. But at the same time, I could see how, when they feel like we're withholding something, there is, this negative perception of that. But when in reality, we're just trying to help. Because, if we look at some of our gram-negative reporting, if you don't do any selective you should be doing selective, but no cascade reporting, there's up to 20 different antibiotics that we could report off of our panel. And, is that really helpful? So again, very interesting concept, Romney, about the fear of loss of knowledge with the cascade reporting approach.
I was struck by that too, and I think I ended up seeing that paper at some point as it was going through, and I was struck by the same thing. But I want to make a slightly different point, which is that, to my mind, the laboratory speaks with authority when we talk about diagnostic testing for infectious diseases. We do not speak with authority when we talk about treating infectious diseases. And so that kind of decision about cascade reporting, or how to report things, and whether to nudge people or to try to educate them, should be made hand in glove with stewardship and infectious diseases, because they are the ones who are the trusted voices when it comes to treatment.
Yeah, I agree totally. The other thing that came up for me when I read the paper that you presented, Alex, was we also couldn't do it here because everybody's allergic to antibiotics in the United States. So you would have to report everything every time because there's a lot of cephalexin allergies there.
I hear you.
I thought it was interesting that they said they would report if the patient was previously treated, right? Or so they actually get treatment level information as well readily in the laboratory. Alex, is that?
Yes, they do. That's right. They have treatment level information. And it raises a good point. I'm glad you mentioned that, Trish, because it raises the point that there was a clinical microbiologist, and at least some of the clinical microbiologists are dual trained in infectious diseases in this lab. I looked him up. And they were overseeing every single report. They were reviewing every single report before it went out. And the authors note that that is a very labor-intensive process, of course, but that's the kind of thing that informed the decision-making process. Yeah. Well, this has been a lot of fun, guys. Thank you very much. Ellie, what are we going to do next?
I don't know. I'm on vacation.
Enjoy the rest of your break.
Thank you.
Trish, Romney, thank you for joining us. It has been a lot of fun.
Thank you.
Thanks so much for having us. I apologize for the tree cutting in the background. My husband decided it was a good time to take out the chainsaw. Really?
We had a lot of additional sounds today. It wasn't just you, it was a lot of us. Look, there's the dog.
Culprit. Oh,
Here he is. Scary noises, right, Becky?
he does look a little ashamed, I have to say.
Yeah.
He seems
We have a new guest on the podcast.
Oh, it's good to
Well,
see
listeners,
you all.
good to see everyone. Listeners, if you have enjoyed this, again, please subscribe to the podcast and rate and review it. And thank you for listening to Editors in Conversation.